One set of unknowns, or were there two boxes?
Just this one box, but there's 27 slides. So fibrous chapter, and there are some repeats in here. So for some of the repeats, I'll just go quickly through it. But this first one is a dermatofibroma, and it is one of the unique types of dermatofibroma. It's kind of an aneurysmal or sclerosing dermatofibroma. And for a lot of these fibrous things, it really comes down to architecture and then cellularity. And you guys have seen lots of dermatofibromas by now, but this is a very small, well-circumscribed lesion. On first glance, because of this unique type and these ectatic large vessels, you may think it's a vascular proliferation. That certainly reasonable, and you'd get down a little deeper and kind of see if it really fulfills itself as something vascular. But even from scan, the central area is just so much spindle cell population, and then there's also, it just sort of kind of fades out to the periphery, and then you can see some of that collagen trapping. So even from scan, it's got that architecture of a dermatofibroma. So then getting in a little bit deeper, the other thing you can see that's classic for dermatofibroma is that the acanthosis of the epidermis overlying it. Most truly neoplastic things like a dermatofibroma or dermatofibrosarcoma protuberans, it atrophies that epidermis, and so in this case it's actually causing acanthosis, and it's very classic for dermatofibroma. Sometimes you can see that folliculosebaceous induction or basaloid induction. It almost can look like a basal cell, and that's also very helpful. But again, as you get closer, even a normal run-of-the-mill dermatofibroma can have larger vessels and vasculature, but this one really has more of this. The predominant cell here is this spindled, fibrous-looking cell proliferation. And it's bland, though. It's not necessarily densely cellular, which is a good thing. And they all kind of look the same. They all look, pretty bland and monotonous. And so those are all good things to point it away from being something bad. And then there's some hemosiderin. That kind of makes sense with the vasculature. Of course, you can also see that in just run-of-the-mill DFs and other things. And at the periphery, again, it kind of fades out, and you see a little bit of, it's not the best collagen trapping, but out here you can kind of see it's sort of trapping some collagen. You almost get some collagen ball trapping formation, but it's really that overall architecture that has you go down that dermatofibroma route. Number 2 is also dermatofibroma, and this one is can be a little challenging because it's tangentially cut. Let me orient it so I like things up straight up and down. So, if you got this would be kind of a hard one, or it could be a hard one or challenging one if they really put this on a test or something, because it seems like it's so far down from the epidermis, but it's actually, most dermatofibromas, they don't really involve the epidermis. They produce that acanthosis, but they're not really, they don't necessarily go right up to the DEJ, and that's a good thing, because if it did, then you'd really want to think of desmoplastic melanoma and some other things that are, coming, like our spindle cell squame, stuff that do come straight off the epidermis. So there's almost like a pseudo-Gren zone in most dermatofibromas, even with that acanthosis. And so this is kind of tangentially cut, and so it just makes it look like it's really far down, and you've got these little follicles here. This is probably part of some folliculosebaceous induction that's just being cut in a weird way. But then at scan, you still have that very well circumscribed kind of DF architecture. It sort of fades out a little bit. You got some collagen ball trapping pretty much throughout, and then particularly at that periphery. And this one is kind of more densely cellular, but it's so well circumscribed that really just fits as a dermatofibroma. And if you look through here and you see giant cells, or if you ever see those ring siderophages, those are almost pathognomonic for dermatofibroma. And we do see some hemosiderin. This is probably a ring siderophage or hemosiderophage, or whatever you want to call it. It's basically a two-tone giant cell with some hemosiderin in it. Where did he go? Oh, there. Yeah, so you can see that's kind of a little ring giant cell with probably some hemosiderin in it. When you see that, that's kind of pathognomonic for a DF. And since there's so many different variants of DF, when you see those, that can certainly be helpful. The other thing that can be pretty helpful are what Dr. Elson likes to call these little collagen donuts. And so this is different kind of from just your run-of-the-mill collagen ball trapping, because this actually has like a little vessel within it and then collagen around it to make it look like this little donut. And that also is almost pathognomonic for dermatofibroma. So overall architecture. So that's the second dermatofibroma. And then I think this one is one as well. Yeah. Oops. So if you got just this cut, and this is sometimes what we get, for routine sign out. It's just this sort of very faint, but still kind of round fibrous proliferation with some hint of collagen trapping, and then you have to look at sort of the other cuts to get more of that fibrous appearance. And I mean, you guys have seen plenty of these. This is classic DF, really good collagen ball trapping at the periphery with the well circumscribed or small fibrous proliferation. Another DF. Okay. So this is number 4. This is a pleomorphic fibroma. And let's see if I can orient this straight up and down. There we go. So from scan, you'd be thinking a lot of different things. It's not very obvious initially that there's really anything fibrous-y going on here. Maybe it's a little more dense collagen. There's a little bit of some perivascular infiltrate, and so maybe your eyes kind of go to that, thinking that there's something inflammatory going on. But as you get in a little bit closer, you can definitely now start to see these very pleomorphic, large, hyperchromatic nuclei in cells that almost look a little stellate. So, hopefully your eyes would then catch that, and you say, well, that's definitely something that's going on. That's probably the primary process. And you would want to think of other things, because there's other things that can do this. So radiation, these look very similar to radiation fibroblasts. If you saw widely ectatic vessels and more almost morphiiform appearance with loss of adnexa, and you have that history, that could certainly fit. But in this case, everything looks, the collagen kind of looks normal. It's not super dense, and these almost have that like floret giant cell or just the kind of stellate fibroblast appearance, and they're just regularly distributed. And so then when you combine that with the history of just sort of this benign little growth, you'd really think pleomorphic fibroma. And these are CD34 positive, so it's one of those things that's CD34 positive is not factor 13 positive. Those giant cells. That's a pleomorphic fibroma. Most of these things are so huge you have to start on 2x. Okay, so this one, let me flip this around too. So this is where I was saying, architecture and cellularity are some of the biggest, the main two things you want to assess when it comes to fibrous things. And so, I'm in 2x, I'm all the way out, and yet this thing is just ginormous. And so it certainly is not a, just a little small, pretty well circumscribed DF. Now DFs can be huge. I think we had one recently that was pretty big, but it still had all the classic kind of benign features. But this one is densely hypercellular throughout, so it doesn't have kind of dense areas, but then still some more normal hypodense areas. Every part of this fibrous proliferation is just incredibly dense, darker blue nuclei, and then it has all those other bad features of DFSP. You can't really see the epidermis that well, but it's not as acanthotic as you'd like to see in a DF. It's usually DFSPs create more of an atrophic epidermis. So if you saw that would point more towards DFSP direction. And then you have this sort of single file percolating fat, single file adipocytes. That goes very well with DFSP. And the pattern here is kind of store form. And so instead of being like what's called a curlicue pattern for a DF, where I actually brought up some pictures I'll show you here in a second, DFSP is more the store form or cartwheel pattern where these larger fascicles are kind of cartwheeling around each other, which sounds funny, and it can be hard to really visualize that until you see a lot of these. But a lot of these patterns can make a difference when you're talking about curlicue, store form, herringbone, those sorts of things. The other thing that's just in terms of overall architecture for DFSP are these parallel patterns here. And so not only are these thick, hyperdense, fibrous strands kind of going through the fat, are they parallel to each other? They're almost parallel to the epidermis. And those things are very highly suggestive of DFSP. And actually this one might even be a Bednar tumor because it has some dendritic pigmented melanocytes within it. There's another Bednar tumor here that's actually labeled Bednar tumor, but with those melanocytes in there, you could probably call it a Bednar tumor. Okay. And this usually has that classic translocation, 1722. So here, if you look up on the screen, I just did this for sort of a view whiz. This is curlicue pattern. So if you ever want to know what some of these things are, where they're just, if you can imagine that with a DF, they all look just nice and dainty and not super dangerous. But then this is more like a store form pattern, and these aren't DFSPs, these pictures here, but just these larger fascicles that are radiating out. And I would focus more on this pinwheel here and this here, because these two histologic pictures aren't really the best for showing that, but you can kind of imagine some of that from the DFSP we just looked at. And then this is the herringbone, which we'll get to in a minute if you ever want to know what herringbone is. It's actually a big deal right now, I think, in tile on backsplashes, right? Herringbone, maybe. Okay, next slide. So this is number 6. This one is nodular fasciitis. And again, I'm on 2X, so this is a pretty large thing, and hopefully as with most things in derm path and even clinical derm, you want to just kind of put things into boxes and categories. And so when you see this, you would want to think, well, this is fibrous. This is probably a fibrous thing. Certainly there are other neoplastic things that can look like this, but there's thickened collagen in here. But then there's just sort of this wispy, what's called the tissue culture appearance to it, and there's some hypodense, almost myxoid areas, even maybe some mucin here, and it's pretty well circumscribed. And when you get down in deeper, it's pretty bland. And you can see there's some, it's all kind of the same, so it's pretty monomorphic, pretty bland appearing, and it wasn't really infiltrating when we were looking at scan. It's not, kind of, got deep fingers kind of invading through the dermis or fat, and it has that, again, that tissue culture appearance to it. And so this really goes with nodular fasciitis. Now there are variants of this. There's the cranial fasciitis, which is kind of more with kids and infants, and then there's proliferative fasciitis, where you can get really funky looking cells within this that can make it hard to distinguish from more worse things. But this overall is really just has more of a bland appearance. And a lot of times, too, in nodular fasciitis, you get a lot of hemorrhage, and so you can kind of see that down here. And usually it's a little bit more pronounced, and that can be a helpful feature of just seeing lots of hemorrhage kind of interspersed throughout this sort of bland, myxoid, tissue culture-like proliferation. That's nodular fasciitis. Okay, number 7. This is one of the, I think, 2 Angiofibromas in here. And I know you guys seen a lot of these, so I won't beat it to death. But, what someone told me once is that, really when you're looking for angiofibroma, I mean, a lot of times it's the classic, it's a bump on the nose, fibrous papule. A lot of these angiofibromas, they all really look similar, but they all have tons of different names. But you have the angio, which is the vessels. Usually you have a little bit increased in maybe larger ectatic vessels. You have the fibro, which is the fibrous around adnexa and those vessels. And then you kind of have the oma, which is sort of the bump that is forming. So if you just remember those three things, you want to try to look for the angio, the fibro, and the oma. That'll get you to angiofibroma. And then what can also be helpful are these little stellate fibroblasts that they're not always there, but they're often present, particularly in the fibrous papules of the nose. And so those are just sort of scattered throughout and almost like what you see in the pleomorphic fibroma, although not usually as hyperchromatic. So fibrous papule or angiofibroma. If it's acral, it could be an acquired digital fibrokeratoma. Okay. Now this is number 8. This is a fibrosarcoma. And I'll be honest, when you look at this from scan, it almost looks like that nodular fasciitis just from looking at it quickly. But this one is not as well circumscribed. I mean, it does sort of appear to be well circumscribed on the edge. But in some of the deeper portions, it's probably invading a lot of collagen areas, and it's probably a larger proliferation. And then what really gets this one is it's even from scan, it is more dense. So that's where you're thinking of that kind of that architecture, but then the cellularity. So it's a much more dense cellular proliferation. It doesn't really have good like myxoid areas or tissue culture fibroblast areas. And then as you get even closer, you can start to make out that herringbone pattern, which sometimes it is incredibly pronounced, where it literally looks like that picture I showed. But you can sort of see it here, because basically you have fascicles that are kind of going in different direction, creating that almost kind of back and forth herringbone pattern. And then if you took the time to kind of search through here, even though it's a relatively bland proliferation, you still will find some atypia, you'll find mitoses, and other things that kind of suggest that it's something bad. But as I mentioned initially, at the very beginning, a lot of these soft tissue things, even a dermatopathologist is going to say, well, this is something soft tissue-y and bad, and let's get a soft tissue pathologist to kind of help me out, because these can be very challenging things. That one was a fibrosarcoma. And DFSPs can have fibrosarcomatous change. Other things can have fibrosarcomatous kind of degeneration and change. Okay, 2x. So this one is fibrous hamartoma of infancy. And this is not that uncommon, so it's something you could potentially see. And it's a true hamartoma, meaning that it's just sort of this haphazard, disorderly proliferation of normal tissue. And so you have, this is usually in infants, and you have essentially all this normal tissue that is just sort of creating this hamartoma. And that includes it's kind of triphasic, and so you have to have, ideally, in a perfect world, you get the mature fat. It's still going to be kind of young infant fat, but you get mature fat, you get kind of a fibroblastic proliferation, and then you get a myxoid component as well. And so when you have those three components, that really helps to, and it's coming off like a scalp of an infant or something, that really helps you to think of fibrous hamartoma of infancy. Now, sometimes it can be predominant, one of the phases predominant, but ideally you get all three phases. And everything with fibrous hamartoma of infancy is relatively bland, and so this kind of looks like normal, kind of fibroblastic proliferation with kind of this myxoid area here, and then some mature fat. So it's really that triphasic appearance and proliferation that makes the fibrous hamartoma of infancy. Okay. So speaking of infantile things, this is the infantile digital fibroma. This is number 10. Or infantile digital fibromatosis. And from scan, you have a little bit of acanthosis of the epidermis, and then you have what appears to be kind of a scar, or certainly something that you would categorize as fibrous in the dermis. And then as you get in closer, you say, well, I guess this could be a scar, although, hopefully you have, in the real world, you have history. Why does this infant have a scar? It's probably coming from, a digit or something. And then you say, as you get in closer, you can start to pick out these very bright pink little eosinophilic globules that are scattered throughout. And these are those actin inclusion bodies that stain with the PTAH and other things, and that really helps to clinch the diagnosis. And you can get mitoses and things, but overall it's not like a wildly pleomorphic proliferation. But you can see these eosinophilic globules pretty well. Okay. Okay, so again, I'm at 2x. This is a huge proliferation. And this one's a little bit more haphazard, and from scan you could be thinking a lot of different things. But then, hopefully your eye starts to catch all these little guys here, and you'd say, well, are those huge, ginormous pleomorphic cells or mitoses or something going on? And you get in a little bit closer, and you start to notice that there are all these osteoclast-like giant cells. And that really helps you, because there's not many things that do that. You can see it in other things. You can see it in the calcifying aponeurotic tumor and other entities. So it's not pathognomonic for this diagnosis. And there are giant cell tumors of soft tissue and bone, and some of them can be actually bad. But this is just giant cell tumor of the tendon sheath. And when you pair it with a more classic history, and these cells with a relatively bland proliferation and these kind of scalloped osteoclast-like giant cells, that's really the only thing that could be at that point. So, especially if, on derm boards, if they show you this, it's really going to pretty much have to be osteoclast or giant cell tumor of the tendon sheath, not one of those other weird things. Okay, this was another Angiofibroma. This is number 12. And since we already did one and we have a lot to get through, I'll just throw it up here briefly. I think this one has some stellate cells as well. A couple in here. And again, you have the angio, a little bit of the fibro, and then the oma. So, Angiofibroma. Okay, so number 13. So this one, a little more challenging, and a lot of these fibrosy things, they're not very fulfilling. This is called written as an AFX, and ideally with a textbook AFX, it comes from the scalp. It's in an elderly guy. You biopsy it, and it's sort of this very atypical pleomorphic spindly proliferation. You can see the epidermis. And this one, you don't even see epidermis. It's just sort of this huge hunk of something that as you get closer in, you do see some atypical cells. And so this one, you'd have to stain it. And that's why it's not very fulfilling per se, because this could be a lot of different things until you stain it. Yes, it has these large hyperchromatic pleomorphic cells. And certainly this could be an AFX. But you'd want to know, how deep is this? Where is it coming from? What's the kind of clinical context? How large is this lesion? Because could this be a pleomorphic undifferentiated sarcoma, or could it be some other dedifferentiated sarcoma or carcinoma? It certainly could be. So, this one in particular is not necessarily the most fulfilling. if you saw something like this and it was close to the epidermis and you kind of almost got underneath the whole thing, then it would be in the SLAM differential, which of course that includes AFX, but again you'd still want to consider all those other things. So by definition AFX really is a diagnosis of exclusion. You have to kind of think of all those other things. This is a really good one, and this is one that you could definitely see on boards because it's important. It's not super rare, and it's a huge. People can make a big mistake on this one, and it can be pretty serious. So this is the Epithelioid sarcoma, and this one you probably saw on here was written that it's actually an 18-year-old male. It's probably from like the arm, proximal arm or something, and it was biopsied twice previously and called GA. And not GA, this is sarcoma that can kill him. So. But you can see why from scan. It does have almost like a palisading granulomatous appearance, and so you can see why this is it can mimic GA. Now, as you get in a little closer, it's kind of more of a dirty granuloma. So you'd also want to think of infectious stuff, and you could kind of go down that route. And maybe when it was previously biopsied, they did some stains and said, well, I don't see anything infectious. It kind of looks like GA, so we'll call it GA. But what really makes this diagnosis is that central necrosis is suggestive of badness. And so even though it also can mean infection, it also can mean more degenerative kind of central necrosis of cancer. And then you have this spindle cell periphery that then sort of transitions into more epithelioid cells. And that right there is kind of what really makes that diagnosis of sort of spindle cell exterior epithelioid cells and then the necrosis. So epithelioid sarcoma, I think it's like loss of NE1, right? Is that the gene? And then if you look really closely, sometimes you'll see evidence of atypia and mitoses and stuff, but it can be deceptively bland. So epithelioid sarcoma. Usually proximal extremities. Okay, this is just a keloid. You guys have seen this a billion times. But for the first year, this bubblegum collagen. This probably was an excision of a dumbbell keloid on someone's ear or something to debulk it. And you can see keloid in hypertrophic scars, and you'd still call them hypertrophic. It's sort of a spectrum, but this one is just chock full of that bubblegum collagen. And so it's keloid. You can get keloidal collagen in other proliferations, but when everything else is bland and there's really just nothing there but those bubblegum collagen, then it's a keloid. This is another DFSP, and so since we've done this one already, I won't really belabor the point, except to point out a few things that will be important here with another unknown, mainly to show you again that there is often this sort of Gren zone. So both for DFs and DFSPs, they don't usually go all the way up to the epidermis. They kind of start somewhere in the dermis. And if they did, if you saw this spindled cell, fibrous-y looking proliferation, and it seemed to start from the epidermis, kind of hang out from the epidermis, you really want to think of other things. So spindle cell squame, desmoplastic melanoma, stuff like that. But this one has the single file percolating fat. It's got the parallel pattern with the that fibrous proliferation extending deep, deep fingers throughout the fat. So in a densely kind of bluish hypercellular fibrous proliferation for DFSP. Okay. Flip this one around. This one is another DFSP, except this one was labeled Bednar tumor because from from scan you can see there's lots of dendritic pigmented melanocytes here, and so makes it more of a Bednar tumor. Okay, this is Elastofibroma dorsi, and again on 2X, pretty large fibrousy looking thing, but this one is not really densely hypercellular, and so you less likely to be concerned about some really horrible bad sarcomatous thing. And, you know, this one can be a little bit challenging. It just sort of has this vague, sort of smudgy collagen pattern, and then maybe, if you're lucky, when you're looking in close, you can start to make out, even without stains, this sort of dystrophic elastic fibers. And, you know, without the condenser, sometimes they're a little refractile, not really as much in this case, but again, you can, you know, when you get in closer, even you can see all this kind of beaded, dystrophic, elastic fibers, even without the use of a stain. And so hopefully you'd see that, and then, you know, I mean, if you're a derm path, and then you'd throw a stain on there, which is the next slide, and really kind of jumps out at you. Yeah. So all those sort of dystrophic, beaded, elastic fibers. Just get that in focus. Kind of looks cool when you look up close at it. There we go. Okay, 19. This one's a sclerotic fibroma, and you'd want to think of Cowden's with that. This isn't really the best sclerotic fibroma ever. It looks acral, or it could just be, you know, some hyperorthokeratosis on top. This one's a little bit faded, but it does have that kind of starry night pattern that you could see with this collagen. A lot of different ways that people have described it, but to me it kind of has almost like this shattered sort of, you know, pretty hypocellular fibrosy look to it. And when it's pinker, there's some good pictures in the book, it's usually a little bit more striking. But you know, even as you get closer in, you can kind of make out that sort of starry night pattern. And there's still cells throughout, but it's pretty hypocellular. The sclerotic fibroma. You can get sclerotic fibromatous change in other entities to include DFs. So sometimes just a run-of-the-mill DF can have, you know, pretty significant sclerotic fibroma-like change to it. This is a Dermatomyofibroma. There's actually two in here. I'll just quickly throw this one up here because the second one's better. I think it's the one from the book. I think the good point to take away from this, though, is that it's not always perfectly east-west. And so I think one of the other cuts on here shows it as well. But, you know, some of these almost look, because of the way it's oriented, like they're kind of going a little bit north-south, or maybe just not as east-west as you would like it to be. But it still is a proliferation that does, you know, seems to be sparing, kind of going around the adnexa, and when you get in closer, you can see it's these little myofibroblastic cells. Let me throw up this other one. Yeah, I think this is the one from the book, and so you can see that you know, it definitely has that sort of east to west appearance to it, but just seems to go right around and ignore the adnexa and not ablate them or push them out of the way. And then, in terms of stains, you know, I could see a question saying, you know, what elastic pattern do you expect to see? And essentially, it's normal. I mean, you have retained elastic fibers throughout this, unlike a scar or most other proliferations. So that's kind of one of the biggest things. And when we see this in derm path, we'll throw a stain on it, and if the elastic fibers are gone, then we say, oh, it's a scar. That's kind of the biggest differential. Okay. This is a adult myofibroma with more of those kind of bluish, almost cartilage-looking nodules. of myofibroblasts. And unlike more of a fibromatosis, you may not necessarily see that kind of corkscrew appearance, and it really is, just seeing those kind of those bluish nodules from scan is pretty characteristic, and once you've seen a couple of these, you can get it right away. But it's not true cartilage; it just kind of looks cartilaginous with that bluish hue. There is a juvenile myofibroma that looks a little bit different. With this adult form, you sometimes see almost like staghorn-like vessels at the periphery that goes with this, and it isn't usually seen as distinctively with the juvenile form of it. You don't necessarily need to know what the juvenile form looks like, but just that there is one. But this, you can see these vessels here too. So that kind of helps make it when you see these bluish nodule collections with the kind of the peripheral staghorn vessels. Almost done. This is just a hypertrophic scar. This is 23. And you can see maybe there's a punch biopsy done here at some point. It's kind of this little cylindrical looking thing, and then months down the road or whenever it was rebiopsied. And it's not, you don't really see keloidal collagen. Maybe there's like one little tiny thing of keloidal collagen there, but you wouldn't really call it a keloid yet. It's just these sort of whorls of scar tissue instead of the more classic east-west with vertical vessels. And you do see some of that here. I mean, you get some east-west fibrous proliferation here with some north-to-south vessels. But then when you start to get those nodular whorls, that's when you can call it a hypertrophic scar. And of course, there's also kind of the clinical hypertrophic scar and keloids that may not match up perfectly with what you see under the microscope. Okay, so this one is meant to be in here to show you the importance of having a broad differential with some of these fibrosy things. So this one was desmoplastic melanoma, and so I think I had a question on here. What stain would you want to get? You'd want to throw a SOX 10 on here or S100 to check for that, because even though it looks pretty fibrosy, and you might say, oh, maybe this is just some sort of ginormous DFSP. There's some odd things here to include. What I keep mentioning previously. This seems to go all the way up to and kind of extend off of the epidermis. The other thing that's a little bit more characteristic of desmoplastic melanoma are these nodular lymphoid aggregates that are throughout. Those go with bad things, but often desmoplastic melanoma, and not as common to see that with DFSP or most fibrosarcomatous things. And it also would behoove you to sort of scan the epidermis. I was looking before, and there's no really good nests, melanocytic nests, or obvious epidermal melanoma, which of course it may have all regressed and kind of just converted into desmoplastic melanoma. But what you can see, if you can imagine it, there are some sort of nests in this papillary dermis, or little collections that look more nested. That you wouldn't have with a fibrosarcomatous process. And so this was a desmoplastic melanoma. And then the last one is a sclerosing hairy-neuroma. And these are EMA positive. They have a textbook answers fingerprint pattern in terms of how that EMA positivity appears. And they're often acral. They have a pretty characteristic appearance too. So these sort of well-defined fibrous collections around a nerve. And that's it.